is a passion project for me, just because I really love engaging with people that often require a different level of care and compassion and empathy. And it's always kind of been a passion project for me. So I started with the Hope program um, about a year and a half ago when we actually launched. So I am one of the co-managers. I also have another co-manager. Her name's Alicia Morales. She's an incredibly gifted woman. However, she's on maternity leave right now, and so you won't get a chance to meet her. But she comes to us actually from the state and the healthcare authority, where she worked within forensic navigation and the True Blood lawsuit. So a lot of her work was with legislation and trying to understand incarceration and inappropriate incarceration and how these systems were converging. Um, my background is a little bit different. I've been doing behavioral health or mental health in Pierce County for the last 18 years. And most recently, I was actually a designated crisis responder with the Tacoma Police Department. I spent about 5 years responding to crisis alongside law enforcement, um, really kind of trying to model different types of interaction, engage with clients in a different way, and provide care. And so when this new position and this new team within the fire department became available, that felt like a natural transition. So would you mind going to the next slide? So HOPE is our team, and it stands for Holistic Outreach Promoting Engagement. And the reason Alicia and I named it that is because we very much believe that every human has their own experience, and they deserve to have the whole person and the whole system treated or evaluated or responded to. And so we're very person centered, we're evidence based, and we do navigate the system from a trauma informed harm reduction model. Um, Tacoma really decided that this was going to be the best way to respond. Um, a lot through the advocacy of an organization called AIR. So their advocacy team is an intentional response. And they went to the city years ago and really just said, we need something different for our community. Traditional emergency response is no longer sufficient. We're having an increase in behavioral health, mental health trauma and crisis. What are we doing to navigate that? And so the city of Tacoma actually engaged with the Matrix Alternative Response Study. Um, and the outcome of that was ultimately we need some alternative response, which is um, our team, which is an alternative level crisis team. They created the HEAL team, which is homeless engagement. So they work a lot in encampments and trying to connect people who are unhoused or unstably housed to resources. And then they created a CSO program, which is a community service officer program, so that the um, law enforcement also has an alternative. So individuals that can just be a more friendly component in the community rather than having to deal with the criminal interactions. So the city has really tried to filter down this new level of a softer response and a more connected response. Um, as you can see here on the graph with the Matrix study, what we were looking at is what types of calls might our team be appropriate for. Um, so oftentimes we were looking at welfare checks. If someone was experiencing suicidal ideation, we wanted to go to those. Oftentimes calls that come in through 911 might be like trespass or unwanted loiterer or assault in a skilled nursing facility. So those are a lot of the calls that we try to pick up. Um, go ahead and go to the next slide. So, our team structure, what we were really hoping to accomplish when we thought of the holistic nature of a human is we wanted someone who could respond to behavioral health and someone that could also evaluate the medical health of the individual. So, we have two response teams, one that responds Sunday to Wednesday from 7 to 5, and then one that responds Wednesday to Saturday from 7 to 5. On our first team, we have a registered nurse and a mental health professional that can respond. And then on our second team, it used to be structured that way, but we unfortunately lost our registered nurse um, last month. And so we transitioned our case manager into a field responder. So we have a mental health professional and a case manager on our second team. We are also we've received permission to hire a peer specialist. So I'm currently in the process of writing that position description and getting it approved through our class and comp department to be able to have someone with lived experience to just increase kind of the depth of knowledge and experience and support and authenticity that we're hoping to bring. Go ahead to the next slide. um, What does our service look like? So, our team currently is dispatchable through 911 within the fire department. So, we've created a workflow where anything that comes in as a psych 2 or a psych 3 call or an overdose 1 or 2, our team is automatically dispatched alongside fire. So, in Pierce County, there is a paramedic protocol that fire has to follow to ensure they are meeting medical standards. So, what that means is when they're on scene, they will work through the process that they need to work through. And then once they've completed their service with the individual, Hope has the chance to take over. So things that we offer are crisis intervention, de-escalation, motivational interviewing. If we have individuals who are experiencing suicidal ideation or potential self-harm, we can provide risk assessment and safety planning. We also do community support and handoff, connection to services, and ultimately, our overarching goal is to provide stability to the individual where they are. I think we all know for a lot of our family members, a transport to the emergency department doesn't always create a solution for our family members. Sometimes it can exacerbate the situation or leave someone feeling unseen, and sometimes it is the correct outcome. And so our team really tries to help create stability where they are and tries to address some of those challenges before they're transported to some other system. And that is also the same with incarceration. So the Tacoma Police Department, they actually have a co-responder program, which is staffed by two DCRs from the multi-care crisis team. So they have a level of authority to be able to detain someone if they meet criteria for the involuntary commitment. Our team does not have that capacity. We come out and can provide every level of care up to the involuntary detention. Um, so we like that we are a voluntary service, and the reason we like that is because I think it gives people freedom to have some empowerment and agency to decide what is best for them, and we will honor that, and oftentimes that creates a little bit of trust. Um, and and tells the individual, we trust you to make those decisions. So hopefully engagement after engagement will continue to just build those relationships. The Tacoma Police Department, if they arrive on scene, they are able to call us through the radio and we can respond alongside them. We've had really positive outcomes where they will call us to the scene and actually wait before entering the household if it says it's mental health. They give us the opportunity to be the first point of contact, as long as it doesn't appear like there's a safety component. They really want people to get the treatment and the connection that they deserve. So they have, with our team, been kind of waiting, letting us come up with a kind of a plan on scene, and then if it's safe, allowing us space to go in, sometimes without them. And then for both fire and law enforcement, if there isn't a safety component and there isn't a medical component that requires someone to go to the hospital, both teams are able to clear, and Hope is able to stay on scene and engage with the individual and the family, um, kind of based on the needs of those individuals. So we can spend a longer amount of time really trying to stabilize whatever's happening. Go ahead to the next slide. Um, so these are just some additional resources for you. I think oftentimes, sorry, I just got new kitties running around. Um, Oftentimes, I think people aren't sure who to call when. And so one of the things that we really want to highlight is 911 is for the highest level of acuity and emergency response crisis intervention. Um, so we just tried to say, if you are advocating for someone with you, or you're looking for mental health support and resources, the new 988 number is actually showing really wonderful outcomes, to be able to support people telephonically. And then if the person then needs additional intervention, depending on if you are wanting evaluation for an involuntary hold, the Pierce County Crisis Line directly connects you to DCRs who are able to make that assessment. And then our team comes out through 911 if there seems like there's a scenario with mental health or behavioral health, to just provide that insulated support to first responders. And then lastly, we've included just 211 for additional resource and referral support. Is there a next slide? Oh, and then just to note, our team covers everywhere the fire department covers in Tacoma, which is, they have 17 stations. So we will cover Tacoma, Fife, and Fircrest. And we also try to support Puyallup Tribe, or the tribal police that are downtown by Tacoma. Next slide. We do have a website, and we do have an email where you're able to reach out with requests at any time. I can also put my information in the chat if that would be helpful. We are still a new program, and we're still trying to grow and figure out how to be helpful to our community. And so I always welcome feedback. If you're noticing trends in your community, or if you have tips or ideas for an insider's perspective to responding to these types of calls, I would love that feedback so we can provide additional perspective to our team, for their own awareness and education and learning. So thank you so much for having me today. I welcome any questions or feedback.
I find this all just really interesting. Really, really helpful. One thing that, so I also spoke with the DCR thing. And the DCR, they ride along with the police. They are not police. They work for multi-care. And something they said was you have to be very intentional with your language around evaluation. Can you kind of speak to that, saying, I want an evaluation versus I would like services?
Absolutely. So, perfect example, there was a family who has really been struggling with a family member recently, and they wanted their son evaluated. However, their languaging when they made the phone call only justified the crisis team sending a crisis therapist and a peer. And a crisis therapist and a peer are not able to evaluate. And so I would say a scenario where it's appropriate to request an evaluation would be if you are concerned your loved one is a danger to themselves, if they're a danger to others, if they are decompensating past their baseline and they require medication services and they aren't willing to take medication voluntarily. If you feel like you have tried every resource and your family member or the person that we're talking about is refusing services or doesn't want to engage, and you're concerned that they are becoming gravely disabled or there's imminent risk to their safety, those are times that you would ask for a DCR evaluation. If you just are concerned that your family members may be in crisis, they're needing some intervention and support, but they don't need an assessment for uh, involuntary commitment, you can call the crisis line or 988 and they will provide telephonic intervention. And then they can also connect you to the crisis team who can come out and do face to face. Our team is more, if stuff really goes wrong, you call 911 emergency. Ideally, we will come out to make that a better, um, more healing experience, or at least a more gentle experience for your loved one. Does that clarify, Peter?
Hmm. Hmm.
Okay. And when a DCR is doing an assessment, the things that they are looking at for um, inpatient is this person gravely disabled? Do they meet grave disability criteria? So are they within cognitive and volitional control? And is there an immediate risk or imminent risk to their health and safety? So if we don't intervene, is there potential that this person cannot care for themselves? They cannot meet their basic needs. They cannot figure out how to find food, shelter, water. Um, do they have something taking place that will really impede their safety? Um, and then are they a danger to themselves? Is there a history of self-harm? Is there a plan? Have they been in compliance with medication, or are they making choices that are very dangerous to themselves? Are they dangerous to others? And is there a danger to property? Um, the other primary component of evaluating these things is you have to assess whether or not those things are because of a mental health disorder. So someone could be acting that way, but if there isn't a mental health disorder to attach to it, it's very difficult for a DCR to be able to write in the languaging to justify why they need mental health treatment. Um, so those are just things to note. Um, I'm trying to think, is there anything else you'd want to know about the DCR process?
I think the other um, question I have is, I spoke with Alicia about this a little bit. What's the expansion? Like, is this a program that's going to be growing in the next few years? It seems like you only seem to work during the daylight hours. That's fine, but is this going to be eventually looking at becoming a 24/7 program?
Such a good question. Um, that is our goal. So, kind of the long term vision for our team was to develop 24/7 staffing, and to become a behavioral health agency so that we could apply for the new endorsement that's coming out for crisis teams that's run through the Healthcare Authority and the BHASOs. So, our long term goal is to be an endorsed crisis team that can dispatch through both 988 and 911 to crisis within the city of Tacoma. Um, However, in order to obtain that endorsement, you do have to have 24/7 staffing. And currently, because we are not yet a BHA, we can't bill for our services. And so all of our services are paid for through the mental health and chemical dependency tax. And so the city council in Tacoma has to vote on those services, um, and what we're able to provide. And so a lot of our capacity right now is dependent on what the budget looks like for the city. So while that can sometimes be challenging, I really love that we can offer services at no cost to the individual in crisis. So there's no need to bill insurance right now. There's none of that. So we can just respond, they get service, and there's nothing tacked onto that. We are currently working toward applying to become a BHA because we would love to bill for those services. In in an ideal world, if we're able to bill for services, we can create more stability in our program, and then we would be able to hire more staff to get to that 24/7 model, where then we could apply for the endorsement and then be able to bill for additional crisis services. So um, I think I was a little naive when I started, thinking like, oh, I'm going to accomplish this in the first 6 months and we're going to be ready to go. And now I think my mindset is it's more of a marathon than a sprint, and it might be another 10 years. So my focus is, how do we provide incredibly quality care with the staff and resource that we have now? And I'm sure you all feel this way about your staff, but um, I feel like my team is, we somehow lucked out and hired some of the most compassionate, well-intentioned, gentle people I've ever met. So I'm very grateful for the staff that we do have. Before we lost our RN, we were covering a swing shift on the tail end of the week. So we did day shift earlier in the week because the call volume seemed to say that that was the busier time of day for mental health. And then swing shift later in the week was kind of the busier time. Um, but to try to solidify numbers and be more consistent with dispatch and to be more consistent in the community, when we lost our RN, we transitioned to all day shift to just say, like, let's create a solid program, let's get good information, let's try to be predictable for the people calling 911, and then grow from there. So it was kind of that, oh, let's take a little step back, let's be really solid at what we're doing, and then take those baby steps toward growth.
Other questions?
You mentioned, the two teams, and this is just out of curiosity. So when you get a call, is everyone from the team going? Are you going in pairs? What's kind of the way that you choose to do that?
Great question. So state law with response, because of the Marty Smith laws, that you go in pairs. And
Mhm.
so our teams are just made up of two individuals per team. So we have the nurse and
Okay.
mental health provider, and we have a van so we can transport individuals. So say we have someone that is not med compliant, but it's because they couldn't get to the pharmacy, we can take them to the pharmacy to pick up their meds. If we have someone
Mhm.
that needs to go to detox, we can actually transport them over to MDC. So we'll call, we'll make sure there's a bed, we can take them to the bed. Um, because so often we find with our population, you have a very small window of opportunity where they're interested in engaging. And so sometimes that requires us to do the whole whole shebang, right? You're making the phone call, you're transporting them, you're sitting with them. There's a level of higher level of care, I guess, that we're trying to provide. So we do have the teams of two so that transport can be more safe, so that if they're on scene, one person can engage directly with the client and the other person can maybe get information from the fire team or the police team
Mhm.
to see what was the dispatch, what is going on, these are the things we can offer. So just trying to um, ensure that both people are able to provide care. um, and then the second team that goes Wednesday to Saturday. The only difference is it's a mental health professional and a case manager. And then one of the additional components to our team is, while dispatch is our primary means of response, we did build out a button in our EMS database where if we're not available, they can click refer to Hope and the information gets sent to us so we can do a face-to-face welfare check the next day, or we can do a follow-up. The same with law enforcement. I created a process for them to be able to send us emails. So like say they responded to a domestic violence situation and the individual that stayed there maybe needed advocacy resources, we can go out and connect with that person and provide them with advocacy or set them up with outpatient therapy. And then we're looking at opening to referral from 2 community partners who we're finding we respond to the most, to try to alleviate some of the requirement of calling 911. But those are small growth and developments in our referral process, just because we still want to be able to respond to 911 calls, as that's our primary service. So it's slowly opening that window to see how we can help the community. I know our advocacy team, the AIR Coalition, would really love direct community response. So they want people to be able to call us and say, hey, can you come? And right now our staffing just doesn't allow for that flexibility. But we're trying to support where we can. I